Welcome, everyone. This is Michelle Jester. I'm the research manager here at the National Association of Community Health Centers. And I want to welcome you all today to our webinar on strategizing workflow models to implement PRAPARE to collect standardized data on the social determinants of health. And for those who aren't familiar with PRAPARE, PRAPARE is a national initiative started by the National Association of Community Health Centers in partnership with the Association of Asian Pacific Community Health Organizations, or APCHO, the Oregon Primary Care Association, and the Institute for Alternative Futures to help health centers and other organizations collect standardized data on the social determinants of health in the electronic health record and really use that data to inform care, inform population health planning, and to inform policy and advocacy as well. So we're going to quickly get started. Again, I sincerely apologize about that. So many of you may be aware of PRAPARE, but you're still trying to figure out how best to get started and what workflow models might be best in your own setting. So today what we hope to do is really give you some strategies that you can apply to figure out what might work best in your own setting, and then be able to compare and contrast different workflow models for collecting data in your own setting. And then finally, we'll outline some ways that you can use staff at your clinic, so both non-clinical staff and clinical staff, to both collect data and then respond to socioeconomic needs identified. So just to make sure everyone is on the same page, PRAPARE is a national standardized patient risk assessment protocol that's really designed to engage patients in assessing and addressing the social determinants of health. So PRAPARE stands for the Protocol for Responding to and Assessing Patients' Assets, Risks, and Experiences. And for us, it's not just a screening tool, but it is also an implementation and action process, because we don't want you guys to just collect data for the sake of collecting data. We want to make sure that it's actionable and that it's able to be used to inform your services, your care planning, and so forth. Great. We know that there are a lot of tools out there, and there are lots of initiatives that may require some tools. So we wanted to kind of talk about why we thought PRAPARE was unique, and I'm going to go through this very quickly given the timing. First of all, PRAPARE is standardized. So in addition to being a standardized tool, we also have PRAPARE measures mapped to standardized codification structures. So it is mapped to the ICD-10 Z codes. It is mapped to meaningful use link codes. It is mapped to SNOMED codes. So it provides that extra layer of standardization. It is also aligned with other national initiatives going on out there, such as for health centers, Uniform Data System, the Institute of Medicine's recommendations, meaningful use recommendations, National Quality Forums recommendations, because we wanted to make sure that you didn't have to collect somewhat similar information for different initiatives, but that it really all aligned for the same cause and the same purpose. PRAPARE is now the most widely used and the dominant social determinants of health risk screening tool used by health centers, and it is increasingly being used by hospitals, health systems, health plans, and getting more interest from different types of payers as well. So PRAPARE is both evidence-based and stakeholder-driven. So it was developed by providers, patients, experts. It was really developed by those who kept workflow in mind. So to that end, in addition to conducting a large environmental scan that linked PRAPARE to research and the evidence, we also had an advisory committee that really kept data burden in mind. It kept sensitivity of the questions in mind. It kept actionability in mind. So it really was developed by fellow peers and others that work in a clinic setting. PRAPARE comes with lots of great free resources. We have free electronic health record templates for the following vendors, so eClinicalWorks, Epic, NextGen, GE Centricity, Greenway Entergy, Meditab, and Cerner's will be coming out later this spring. We have a free PRAPARE Implementation Action Toolkit that has a lot of great resources that are based on early adopters and their lessons learned and their best practices. So we encourage you guys to check those out on our website at nac.org/PRAPARE. And then finally, PRAPARE is meant to be flexible. So while we want it to be standardized, and we think it's important to standardize the need so that you can use that data for actionable purposes, we still think it's important that the implementation process be flexible. So with that, PRAPARE does not require a specific workflow model. You can use any number of workflow models. There is no right or wrong way to implement PRAPARE. It's really designed to fit within existing workflows and something that can be combined with other tools or assessments that you may have to do. And also it's meant to really help your organization build and have relationships and conversations with your patients. So to that end, we do not advocate that PRAPARE be used as a strict assessment tool where you have to ask each question verbatim, question by question, but really, again, it's meant to help guide you in having a conversation with the patient. So again, we really advocate that you standardize the need, so you standardize the patient's response in the electronic health record, but to get to that point, you can have a conversation as opposed to saying each question verbatim. I'm going to skip this slide just for the sake of time, but please know that you can use this data for multiple levels, from the patient level to the organizational level to the community, and then for the larger policy level as well. Okay, so getting started, strategizing workflow models. So we believe that a great way to start thinking about fitting PRAPARE into everything else that you have going on is to use the CDS 5 Rights framework. So this is a great way to help you determine how best to implement PRAPARE in your own environment. So the CDS 5 Rights framework helps you think through those critical questions. So the who, the when, the where, the how, and the what types of questions of workflows and projects. So applying this to PRAPARE implementation to collect data on the social determinants, it's first really important to think about the what, so having that right information. So with this, you should ask yourself, what information in PRAPARE do you already routinely collect? So if you look at PRAPARE, you'll notice a lot of it is demographic information, which you may already collect at registration. So for the PRAPARE EHR templates that we have developed currently, all of those EHR templates automatically map to the demographic information as part of that vendor. So it will automatically populate demographic information from, let's say, if your front desk is filling that out, it will pull that into the PRAPARE template, so you don't need to ask that twice. However, that's demographic information, so like race, ethnicity, income, household size, those types of questions. But you may ask other questions that are in PRAPARE, but you may ask those because of your participation in other initiatives. So again, I think it's a helpful exercise to really kind of walk through question by question in PRAPARE and figure out, are you already collecting some of that information? And if so, how does that affect the workflow of administering PRAPARE? So maybe you don't have to administer all of the PRAPARE questions, but maybe it's a subset because you're asking the others at another point of the clinic visit. The next question to think about is how, or having the right format. So how do you want to collect this information, and in what manner do you want to collect it? Would you prefer that patients complete the assessment on their own in a self-assessment because you want to give them that privacy and let them feel comfortable answering the questions on their own? Or would you prefer to have a staff person implement PRAPARE in person with the patient, again, to kind of be able to build that relationship with the patient, help explain anything to them, and then be able to talk about if there's anything they'd like to prioritize to address. The next question to think about is who. So with this, there's several sub-questions. So who will collect the data? Who has access to the EHR to actually input the data? That's a very important question to think about. Who needs to see the information to inform care? And who will respond to needs identified? For some of you guys, this may be the same staff. In other cases, you may have some staff that collect the data and other staff that respond to the data, and then other staff that use the data to inform care. Again, like, keep in mind, there's no right or wrong way to do this. It's more just a matter of figuring out for yourselves what works best in your own clinic workflow. So I will go into kind of the ins and outs of the who a little bit more as we present workflow models. But again, some prefer to use the clinical staff. Some prefer to use non-clinical staff, and I'll kind of go through the advantages and trade-offs of each of those. The next question to think about is when. So what's the right time in the clinic workflow to collect this information? For some, maybe it's best to do this before the patient sees the provider. So again, this could be before the patient even comes to the clinic. This could be while the patient is waiting in the waiting room, but before seeing the provider. Some of you may want to do it while the patient is roomed, so kind of during the visit. And then some of you may prefer to do it after the visit with the provider, just to make sure that it's not delayed. And then finally is where. So where are we collecting this information? And then also, where do we need to share and display this information? Because again, it's not just about collecting it, it's about making sure that it's used to inform point of care, to inform your services and your planning. So in regards to where you're collecting this information, many people choose to use the waiting room. Some people prefer not to choose the waiting room because they feel that it's either too busy or it's not private enough, so they may have extra private offices that they might be able to use to administer PRAPARE. And then in regards to where to share the information, think about sharing it during team huddles. Some of you may now do case conferencing for complex patients. That's a great opportunity to share PRAPARE data. We've seen some organizations that kind of post care team dashboards to kind of show how many have been collected and kind of like helps kind of spur some healthy competition amongst everyone, you know, and helping to paint that fuller picture of their patient population. So things to consider as you're thinking about implementing PRAPARE in your own setting. Some other things to consider when you're strategizing your implementation plans are, what are those other activities that PRAPARE could leverage or add value to? Again, we don't want this to be yet one more thing that is on your plate that you have to do, but it's really meant to be something that's adding value to work that you're already doing. So if you're a patient-centered medical home, how does PRAPARE really kind of take you to the next level? If you're in a delivery system transformation initiative, maybe PRAPARE will help you identify those key community partners you should be working with, or helping you really kind of lower costs by lowering hospitalizations and ED visits if you're really meeting patients' non-clinical needs. You know, all of those types of things. To really think about how it's informing and adding value to those other efforts. A great way to help to kind of determine this that our partner at the Oregon Primary Care Association piloted was a 3x10 approach. So this is a great way to kind of get your feet wet and get some staff feedback and patient feedback for that matter in implementing PRAPARE. So with this, you would pick 3 questions from PRAPARE. So you can engage a small cohort of staff and they can pick 3 questions from PRAPARE. And then you administer those 3 questions with just 10 patients. So again, a very small kind of PDSA. And after you do that, you kind of bring the staff and the patients together to kind of talk about what they learned. And we've had great experiences with staff kind of really understanding how they could apply this information to their own work, what trends they are seeing, hearing from patients that they feel comfortable answering and that they appreciate being asked these types of questions. So I think it's a great way to kind of think through how the data will be used once you kind of have like a very small subset of data. Another thing to consider is if you will have a population of focus. Some may decide that you want to just do it across your general population, and that's great because we've had experiences with some organizations that if they choose a subset of a population, they find the needs of that subset, but it may not be indicative across the entire population. Others may choose to have a population of focus. For instance, if you want to focus on patients that have uncontrolled hypertension or diabetes, because that is a more complex population, and so you really want to address kind of their needs. But with this, if you choose a population of focus, again, that may influence the workflow that you use. So again, if you're focusing on patients with uncontrolled hypertension or diabetes, you may want to consider using your chronic disease management team. If you're choosing to focus on patients with a behavioral health condition, obviously kind of using your behavioral health staff, or if you have integration specialists, might be a great way to kind of incorporate PRAPARE with that as well. And then finally, another thing to consider is what resources are available to respond to needs identified. So if you are very fortunate that your community does have a lot of resources, it may impact that potentially you're using your non-clinical staff more because they potentially might have more knowledge about the resources in the community and then would be able to really help patients get that warm handoff to those services or those resources. Okay, so those are some general strategies and kind of things to think about as you're considering implementing PRAPARE. Now what I want to do is kind of walk through some sample workflow models and their associated trade-offs, again, so that you can kind of try to picture what might work best in your own setting. So just so everyone knows, what I'm about to go through is part of our PRAPARE Implementation and Action Toolkit, which is at our website, nac.org/prepare. And what I'm going through is essentially Chapter 5. We are going to be adding a couple extra workflows on there, like any day now. For those that want some extra resources, please feel free to check out Chapter 5. Okay, so one of the first workflow models that you can use is non-clinical staff after the visit. So with this workflow model, the patient has the clinical visit with the provider, and then the provider refers the patients to non-clinical staff. And that is when the non-clinical staff administers PRAPARE with the patient and then refers the patient to appropriate resources and services or provides that warm handoff. Now, many of you may have different types of non-clinical staff. These can be community health workers. These could be outreach and enrollment assistant workers. These could be eligibility assistant staff. There's a wide range of non-clinical staff that you can use. And the upside of using non-clinical staff is that, again, they're often from the community, and so they can more easily relate to the patients. They understand their needs. They can build those trusting relationships. They're also, again, more aware of community resources that are available. As great as the internet is, like we have been amazed at how many community resources are still kind of passed down via word of mouth in terms of like best places to go or best times to go or what's really offered. So again, like your non-clinical staff could be a huge resource when it comes to that. And a huge bonus of using non-clinical staff is that it really kind of ensures that the staff person that is administering PRAPARE is also the one that's addressing the needs. That's key because then the patient really kind of feels like it comes full circle. They really understand. They're seeing it, how their questions are immediately informing the action. So that's something to consider. So the advantages of using this model, so non-clinical staff after the visit, is that, of course, it doesn't delay the visit with the provider because it comes after the visit with the provider. And again, by doing it after the visit, you can immediately administer PRAPARE and then immediately do a warm handoff to services and resources. The trade-offs of using this model is that because it occurs after the clinic visit, the provider doesn't have that data available at the point of care to really inform the treatment plan. And by doing it after the clinic visit, it could potentially lengthen the overall visit time. For some patients, this may not be a burden, but for other patients, when they were coming in for one reason and then they're getting asked these other questions, that could be a consideration. Again, we found that most patients really appreciate being asked these types of questions, but that's something to consider. Another model that you can use is pretty much the same, so using non-clinical staff, but before the clinical visit. So with this kind of model, the patient is waiting to see the provider. And then what's happening is that the non-clinical staff administers PRAPARE while the patient is waiting. So this could, again, be in the waiting area, or it could be like maybe a non-clinical staff like identifies a patient that might be waiting for a while in the waiting room, but then asks them to come into like one of their private offices, so there's some privacy, but it occurs before the visit. So this happens, and then after the PRAPARE assessment is done and the provider is ready, the patient sees the provider, and then because this data is inputted into the electronic health record, the provider has the opportunity and the capability of reviewing that data during the visit so that it can really inform the treatment plan. So let's say PRAPARE really identified that a patient was feeling socially isolated. The provider could use that information to refer the patient to group education classes or group diabetes management classes. So it's not just about managing the diabetes, but then also helping to address the feeling of social isolation. Same thing with if PRAPARE discovers that the patient is having utility issues, the provider might think twice before prescribing a medication that requires refrigeration. You know, so that's the key thing with this model, is that by doing it before the visit, the provider really has that opportunity to inform the treatment plan. Then after the patient sees the provider may then refer the non-clinical patient, refer the patient back to the non-clinical staff for the appropriate resources and services. So the advantage of this model is that you're using that value-added time when that patient is essentially like just otherwise waiting. You know, they're not doing anything. So by doing it before the visit, you're not necessarily lengthening the overall visit, but you're just kind of using time when the patient would otherwise just be sitting around waiting. And a huge advantage is that, again, the provider can use it to inform care. The trade-off with this model is one of two things. One is that if the provider is ready to see the patient, the PRAPARE assessment could be interrupted, and so you may not have a full, complete PRAPARE assessment, which, as we've learned, it's really important to get that full picture of the patient. Another trade-off with this is that if the PRAPARE assessment is still going on and the provider is ready to see the patient, that could delay the visit with the provider, which I know no one wants to do. So just some things to consider using this model. Some of you guys may consider using clinical staff during the visit. So with this kind of workflow model, the patient would be roomed in the exam room, so they're in a private room. And then what may happen is that clinical staff, whether it's like a nurse or a medical assistant, would come into the exam room and administer PRAPARE while they're doing their vitals. So, you know, they can take blood pressure, ask some questions, or do a quick couple questions while doing some other vitals. And the clinical staff can input this data in the EHR. With this, the clinical staff can refer the patient to services or non-clinical staff to address the needs that they can go to after the visit with the provider, but they can go ahead and provide that warm handoff or those sheets of paper that may have community resources on them. And then the provider can then come into the room and again use the PRAPARE data to inform the visit. So when people want to use clinical staff, it's often related to the fact that clinical staff often already have training in collecting sensitive information, and so they feel that they could apply that training to PRAPARE and other socioeconomic kind of data. Whereas non-clinical staff may have training in motivational interviewing, empathic inquiry type methods. So it's just different types of training for the different types of staff. The trade-offs with this model is that obviously you may be using billable staff to conduct assessments. And just as with the last model, anytime that it's before the provider visit, the PRAPARE assessment could be interrupted or it could delay the visit with the provider. And also the clinical staff may not be as knowledgeable about community resources to respond to needs. That's not always the case, but just something to consider, but something to talk about with your staff. Another option is to use care coordinators during the clinical visit. So with this model, the patient would see the provider, and then the provider would refer the patient to a care coordinator if the patient is considered kind of at risk. and at risk would be defined by your own organization. Once the patient arrives with the care coordinators would administer PRAPARE along with other necessary assessments. So again, this might be another health risk assessment that you are required to do. This might be some care coordination assessments that if a patient is referred that they are asked. But the upside of this is that if the care coordinators are asking other questions or doing other assessments, you can easily align PRAPARE with those, and that if you identify similar needs, you can then address those similar needs, because more likely than not, these multiple assessments are likely asking similar things and have complementary information with them. And then finally, the care coordinators, after they administer PRAPARE on the other assessments, can either provide that intensive or that interim care coordination, depending on if and how the patient agrees to a self-management plan. So then you're also able to then kind of address the needs that are arised by conducting these similar assessments. The trade-off with this model is that you guys probably all, are aware, care coordinators have a lot of other care coordination responsibilities. They're often seeing some of the most complex patients, and so that's something to consider. But again, hopefully having that conversation around how does PRAPARE add value to the work that you're already doing, this is a good example of that. We talked about this a little bit earlier, but something else to consider is using special staffing teams, like a chronic disease management team. So a chronic disease management team would be like a multidisciplinary team consisting of whether nurses or health educators, and then along with social workers and dietitians. So you really have a comprehensive team that incorporates both clinical and non-clinical staff that you could then use to assess and address patient social determinants, and then use that data for care planning. With these types of teams, they also have kind of established workflow models, and they have those established conversation structures and discussion tactics that, since they're working as one team, they're talking about their patients all the time and in a collaborative way. So PRAPARE is a great way to kind of inform the care that's provided. So in this workflow model, the patient would be roomed in the exam room. The chronic disease management team would then administer PRAPARE, and then the team would discuss, what's the appropriate, action plan given what we know, and discuss the appropriate care and the appropriate services. And then the team would be able to refer the patient to those services and resources, again, because you have both clinical and non-clinical staff. So a trade-off with this is that you could lengthen the visit with a chronic disease management team, and again, some of these staff may be billable staff, so something to consider. But it does kind of prevent other staff who may conduct other screenings, like medical assistants, from becoming overburdened. Many of you likely serve very diverse populations and may serve patients who speak a variety of languages and come from different cultural backgrounds, and so you may want to consider using translated versions of PRAPARE and interpreters. So with this, patients would be identified at registration if they have a language need. And then we would encourage that it's not just an interpreter, but then also a staff person administer PRAPARE with the patient, so you kind of have that consistency. And often what's been done is that the patient is given a paper translated version of PRAPARE. We do have a couple of translated versions on our website, and we're working on others. But then in addition to that, so the patient can kind of visually see, and then you have the interpreter there to explain. And then this would occur before the visit, so that, similar to the others, the provider can use that data, and then the staff would respond to the needs. So the advantage of this is that the interpreters can really help provide explanations or cultural context to PRAPARE questions. We've learned that with some of our early adopting organizations that, for instance, a question around veteran status, some patients that may come from cultural backgrounds would ask, do you mean U.S. military service, or, I served in Vietnam, or served for a different army, so what is the question asking? So again, it's helpful to have that interpreter there to kind of explain. And while the question, at least in PRAPARE, is around benefits purposes, it's still important to know potentially about military service and other areas as well. And obviously, interpreters that are recruited from the community can help build trust and relationships with the patients. The trade-offs with this is that interpreters obviously are not always available. With this model, it would take more time to administer, so that's something to consider, especially if you're doing this before the visit with the provider, is to make sure that you do have enough sufficient time to administer PRAPARE. And then again, the assessment could be interrupted if the provider is ready to see the patient. Something one of our early adopting organizations piloted and really kind of created was what they called a no wrong door approach. And this is essentially a model that says that anyone that wants to participate in this is welcome to. And it worked really well for them because the staff got really bought into this because they felt that they were really contributing to painting a fuller picture of their patients and really kind of helping to make an impact beyond just providing them with medical care, but really kind of extending that into the community as well. So an example of this would be that the patient checks in at the front desk, and so the front desk staff asks some of the PRAPARE questions. Then the patient may be roomed in the exam room, so then some clinical staff come in, like a nurse, and ask some additional PRAPARE questions. Then the patient can see the provider, and then finally, if the patient's referred to some non-clinical staff after the visit, then the non-clinical staff can complete the PRAPARE assessment and ask the remaining PRAPARE questions. The upside of using this model, again, is like staff really get bought in. If you have people that are really interested, I would very much encourage you to use those volunteers because they will become your champions, and they find that it really kind of adds value to their work. Some think that it's good to have kind of like special outside initiatives that adds extra things to their day-to-day. So we really encourage you to take any and all volunteers. But it does require coordination, very much so, to ensure staff are aware of who is collecting what kind of data. I mean, obviously you would be able to see what's populated in the EHR, but it's probably good to have kind of a set workflow model that in general, you know, if your front desk staff are interested, they ask, you know, the demographic questions. If your clinical staff are interested, they ask stress question and social isolation question, or the, you know, a set type of questions, and same with non-clinical staff. And then, something else to consider is not all staff have access to the electronic health record to input the data, so that's a key thing. One of our early adopting organizations really wanted to use financial counselors because they felt that they had the right training and they're kind of, you know, talking about similar things, so then they discovered that they actually don't have access to the EHR. They have access to the practice management system, but outside of demographics, that data didn't match over to the EHR, and so they had to think about using a different kind of staff. And then last but not least, certainly, is self-assessment approaches. So these are becoming increasingly popular, whether it's using PRAPARE via email, having patients fill PRAPARE out on a tablet or an iPad in the waiting room or in the exam room. So obviously with self-assessment, again, some people believe that patients feel more honest and more comfortable answering these questions, that they're kind of filling it out on their own. With these, obviously, if you're doing it before the patient even comes to the clinic, so if you send it via email, you know, you're not lengthening the visit time. You have that information at the forefront, so you can use it to inform the visit. If you're using tablets or kiosks, you know, you're using that waiting time, and the patient would otherwise just kind of be sitting around waiting. So there are lots of advantages to this. The major trade-offs with this, though, is that obviously it does not really facilitate that patient and care team relationship building. And so it's really important that if that's the priority of yours, that you make sure you build in that follow-up once the patient has completed the assessment. So whether it's via a phone call to like potentially ask the patient if there's anything they wanted to discuss or anything they'd like to prioritize, or at their next clinic visit to talk about their responses and if there's anything they wanted to do to address them. But what I have kind of up here on the slide is using an email system. So with using, like building PRAPARE into email and sending it out before a patient's visit, if you have a large patient population or you may lack adequate staff who can implement PRAPARE in person during your workflow, this is a good consideration. Also, if you want to align like your data collection efforts with other direct patient communication methods, this is another good consideration. So some people have started to use this because they want to drive people to their patient portal, so something to consider. If you're considering using an email approach, the advantages of it are that you can obviously reach a wide swath of your population very easily and very quickly. And then you can also get the data quickly to inform your care transformation and your population health planning. It's very low cost, and it does not take it's not a big burden on staff to build an email message and send it out. And we found that with the organization that really kind of piloted this approach, we found that it was very quick for patients to fill out the survey, only just 35 seconds. And again, they felt comfortable answering the questions. A key thing with this is that be sure to build it as a mobile version as well. With this particular organization, they found that over 60% of their respondents used the mobile version. The trade-offs are that you may not reach your full patient population because it would be those that have a valid email address. It requires some IT-savvy staff to connect the email system to your electronic health records, so something to keep in mind. And again, you may not necessarily have real-time feedback on the patient's experience using this, although you could build some evaluation or satisfaction questions in there if you like. So with this, it's good to have a multidisciplinary team to develop and test the PRAPARE message, and also have patients on that team to really craft that message. And with that email message, we think it's good to call out the purpose, like why is this information being collected, make sure it's the appropriate reading level, talk about how the information would be stored, and how it will be used to inform care and services. So make sure it's all HIPAA compliant. You can incorporate some normalizing messages in your email to kind of make patients feel like they're not the only ones going through this. So you can say, you know, like, did you know that 1 in 5 people in our state do not always have enough food, or, you know, those kinds of normalizing messages. Include visuals if possible to prevent issues with literacy. And then it will require some follow-up, and I think that's to be expected. But it is an interesting way to gather this data. And we found with this organization that piloted it that patients that were seen more recently and patients that were more active with the patient portal were more likely to complete PRAPARE via email. And again, can't stress this enough, as much as you can after a patient completes the assessment via email, follow up to see if they would like to discuss the results over the phone or at their next clinic visit. There's an opportunity with this that you can partner with like a social services platform, whether that's a 211, an Aunt Bertha, a Healthify, a NowPal. There's lots of platforms out there, but you can connect that the responses generated through the email system with this social service platform that you know, that the social service platform can see that based on your responses, you know, here are some services in your community that might be able to help you address this need or something. That way you're at least providing some like referral instantaneously as soon as the patient fills it out, but then you can follow up with a staff person to build that relationship, build that trust, see if there's anything the patient wants to prioritize or if they have any questions around that. Okay, so despite the long delay, again, I really apologize about that, we do have some time for questions. I do see some that are asking about the recorded presentation. Yes, we will post this on our website along with the slides. Happy to do that. If you are interested in getting the latest updates or new other webinars, feel free to email me. My email is up on the screen right there, and we can put you on our listserv. Again, we encourage you to check out our website. And I am going to, I see some questions. Oh, and Shell, do you mind going to my computer to see if people put questions in? Sorry. I had to change computers given the audio, so I apologize about that. And then while I'm going through these questions, I'm also going to ask, Shell, I have a poll, if you wouldn't mind launching the poll as well. We'd love some feedback on what you thought of the webinar. So, okay, do you guys have an example? Oops, there goes the poll. Great. So there is a poll that's launched. Thank you, Shell. If you guys wouldn't mind responding to those poll questions as I kind of go through questions that were submitted. Okay, so there's a comment and a question around, like, we're trying to roll this out, but we can't assess every patient. So they're saying that they need a triage mechanism so that we can ask a few questions to all patients and then dive deeper with those who have red flags. We understand that. Again, we think it's really important to get a general sense of your population to figure out what the risks are, because while you may do a subset that may not be indicative of your general population, but I definitely understand as you're starting out, it's very daunting to think about doing this with every patient, and so we are totally advocates of, again, choosing populations of focus, or again, if you want to prioritize certain questions, we understand that. Again, what you don't know is what you don't know, and so that's why we try to advocate that you use the full PRAPARE assessment, but we understand that that could be a big lift. Some organizations choose certain PRAPARE questions based on kind of their gut feeling, what they think are important needs, but then we've had experiences of organizations that do that, that then once they administer the full PRAPARE assessment tool, that they then discover that there were needs that they had no idea that they had. In some instances, if there was a need that they thought was lessening because there had been investment in it, so in one community there had been a fair bit of investment in housing already, and so they didn't think housing was as big of a need, but once they administered PRAPARE, they realized that despite the investment, housing still very much was a need, and so they were able to use that data to go back to the local funders and kind of advocate that continued and even more investment be encouraged for housing. There's a question on what has your experience been with providers using a separate care coordination system to do the PRAPARE assessments instead of using an EMR system. Using a care coordination system is easier to access from staff outside medical facility. So to my knowledge, I have heard interest in this, but I am not aware of anyone that has actually done this. And if this is something that people are interested in, please contact me, because we would need to work out a licensing agreement with this other software to provide them with the intellectual property to build PRAPARE into another software system. So that's not something that we're opposed to at all. I just don't know if it's been done yet, and we would just need to work with the vendor to build it into another system. I know of some that really want to build PRAPARE into like population health analytics type tools so that they have kind of that extra layer of use of the data. And so that's something that we've been working with a couple of vendors on as well to create some interesting like reporting and dashboards and whatnot. Some people are asking, yes, Slides will be on our website, nac.org/prepare, but it's P-R-A-P-A-R-E, not P-R-E-P-A-R-E. Someone is asking how many providers and community health centers are utilizing the PRAPARE screening tool in their practice. So we have hundreds, so probably getting close to 1,000 organizations using PRAPARE. I don't know about number of providers. We unfortunately don't have that level of data. But what we hope to do very soon in the next couple weeks is field a survey to our listserv to get a better sense of how different organizations are using PRAPARE. So we know that there's some hospitals and health systems that are using PRAPARE, but we don't know necessarily how they're doing it, and so we'd love to learn more about that. We know very well how different health centers are using PRAPARE, but not necessarily these other organizations. So we're hoping maybe come late April that we'll have like a much better sense of exactly how PRAPARE is being used and implemented in different settings. Okay, someone is asking, you mentioned this form is built in Centricity. Does that mean that it is available for free text for answers, or is it built to pull in the information that is already collected in other areas in the EMR? So it is a template. So with each of the EHRs, it is a template. Now, again, for demographic information, it will pull that data from the practice management system in the case of Centricity. So again, you don't have to ask those you don't have to ask those questions twice. But then everything else are things that you will be asking. Again, if it is already housed in another part of the EHR, it is mapped to that part of the EHR, but there is a question in PRAPARE such that if you fill it out there, it populates into the other section. Like, let's say if you have a social history section in Centricity, I'm not sure if that's the case or not, that it is mapped because, again, we didn't want to build the same question, and that's the case with other vendors as well, that if it's already being collected in a different area, it's mapped to that other area, so hopefully that makes sense. Some people are asking kind of like how do they access the EHR templates. So you can go to our website, so nac.org/prepare, P-R-A-P-A-R-E. It's on the slide right in front. And if you go to our toolkit, our PRAPARE Implementation Action Toolkit, you will find the EHR templates on Chapter 4, and you will need to sign an end-user license agreement, but then you can access either the template as a text file that you can then upload into your own system, or it might be a link to the correct portal on the vendor website. So, yeah, feel free to go through there. I'm noticing time. People are asking that they'd like more information on how others are using PRAPARE. Yep, we are organizing more webinars to provide more experiences and lessons learned. All of the information that I presented today was based on early adopters' experiences, and so these are some of the lessons learned that we've pulled out from those. But we will do those with upcoming webinars as well. So again, if you're interested, feel free to email me to join our listserv, and you'll be notified of other updates. So again, I sincerely apologize about the delay, but I thank you for joining, and please reach out if you have any other questions, and thank you so much for joining.